Good morning, good evening, depending on where you're joining us from the globe. Welcome to our, sorry, just getting rid of this, okay. Welcome to our webinar series 7, week 2. This is around infection prevention and control, focusing on leadership and management, but this mainly focused on healthcare workers. Just a few things that we should note before we begin. Sorry, just give me a bit of problems. Okay, I'll just. Okay, there we go. Sorry about that. So this is our agenda for today. Our topic will be focusing on monitoring and evaluation today. And we'll be having two presenters talking to us about that, presenting at healthcare facility level, as well as talking about country experience at national level. We're going to also have COVID updates from CDC, and then of course the Q&A, and then before we close off, just a few things that we should note before we begin. Certificates of attendance will be given to all participants, provided that they attend 4 of the 6 weeks of the series, and then that they stay on for 60 minutes of the 90 minutes that this session actually goes on for. Can we all please mute our microphones and also switch off our videos? This will ensure that we give you quality presentations. We cannot also respond to any questions during the session, and we also cannot respond to comments. So if you've got anything vital, maybe that you'd like to contribute in terms of views, or that you'd like panelists to address, please put it in the Q&A. Also put all your questions in the Q&A box so that we can attend to them. We cannot attend to all questions after each presentation, so all questions will be answered at the end of all presentations as we round off our day. All sessions are recorded, and all of these recordings will be made available to all our registered participants. And with that being said, I'd like to introduce our first presenter. Our first presenter is Dr. Dennis Buyonga with the Africa CDC, and he'll be giving us an update on COVID-19 situation in Africa. Thank you. Over to you, Dr. Buyonga.
Thank you. Good morning, all, and good afternoon, depending on where we are. Am I audible?
Yes, you are.
Thank you. So, as stated, I'm Dennis Buyonga with Africa CDC, and I will take you through the COVID-19 situation as of today. So, up to today, we have globally, we have approximately 163 million confirmed cases, with 3.3 million deaths, making the case fatality rate to 2.1%. So these numbers has not changed. The global distribution cases has not changed much this week, and this week we have approximately 3.8 million new cases reported globally, and 50% of this coming from India alone. In Africa, we have approximately 4.7 million cases with 127,000 deaths, bringing the case fatality rate to 2.7%. And we have more than 4.2 million recoveries, which is approximately 90% of cases. The distribution of accumulated cases by AU member state has not changed, and we are still seeing an overall downward trend in new cases for the continent this week. And we have approximately 33,000 cases and 1,100 new deaths this week. And 73% of the new cases have been reported from the northern and southern regions. And because this is mid of the week, usually we have a more detailed report by the end of the week. And so on our next series, we might have a more detailed explanation on the distribution of cases, which will cover previous weeks. So that is the situation of COVID-19 in the region, which I prepared to give today. So that's all for me. Thank you.
Thank you so much, Dr. Nyonga, for that update on the COVID-19 situation in Africa. As we move along, I would like to introduce our next presenter. Our next presenter is Anthony Twyman. Anthony is an accomplished infection prevention and control specialist with over 10 years of experience from healthcare facility level all the way to international level. So we know that Anthony does have a wealth of infection prevention and control knowledge. Anthony will be taking us through monitoring and evaluation of infection prevention and control in healthcare programs. So he'll be looking at healthcare level and also looking at national district level. So the main focus will be goals, planning, and tools around monitoring and evaluation. Thank you so much, and over to you, Anthony.
Thank you so much, and happy to be here. Oh, my video won't allow me to put it on for some reason, but I will show my face when I can. Okay. Hi, everyone. My name is Anthony Twyman. Thank you for the kind words and introduction. Today, I'm here representing ICAN specifically for today's webinar. Hopefully, everyone can see my screen okay. And as discussed already, I will be sort of taking us through a bit on the monitoring evaluation, but kind of focusing on specific ICAN work that we do that incorporates the M&E component. So just thinking, before we go into that, I'm sure this is familiar for everyone, and I apologize if I bore you. But just taking us back to some key definitions. Oh, it's moving without my control there. Just thinking about what does monitoring and evaluation mean, right? So the monitoring progress and evaluating results are key functions to improve the performance, right? If we want to know something is working, if we want to know if we're having any impact, this is all of that sort of goes underneath the umbrella of monitoring and evaluation. We want to show whether a service or program is accomplishing its goals. So what have we set out to do, and are we achieving that? It identifies program weaknesses, strengths, areas of improvement or revision, maybe something that we can change, and then and areas of the program that meet or exceed expectations. So I mean, again, this is all familiar to you, I am no doubt, and there's so many things out there that can help us in our monitoring and evaluation journey. Today, I'm going to stick a little bit more to ICAN specific, but I do wear two hats also with WHO, and there's many tools coming out, and we think about the core components. Hopefully that is familiar terminology to a lot of you, but if you think about specifically core component 6, monitoring and evaluation of IPC practices. So we know that at an international level, this is something we need to be doing when it comes to infection prevention and control. Audit, it's another word that often gets thrown around a lot. And essentially it's part and parcel of M&E program, right? We do specific audits to establish what exists within health facilities, and we measure these against existing structures, policies, practices. It's a continuous part of monitoring and evaluation. And the additional piece here and that we really need to think about is the feedback when we do these audits into quality improvement to help inform best practice, right? And so when we're trying to achieve behavior change. And when we think about the field of IPC, it is all about behavior change. You know, we can get the fanciest items, anything, you know, we can say it all has to be alcohol hand gel, but if no one's using it, it's ineffective. And so all of these pieces need to fit together in order for you to be able to actually get the change in behavior that you want to see. So when we do things like audits, super important to think about that feedback aspect at an individual level where we can get specific individual behavior change, but also at a bigger level where we feed back the results that we're getting, that we're seeing the trends, what's happening over time. And we want to share that broadly or more widely within a health facility or even national level, which again sort of goes to a broader behavior change, system change level. Just some key things about characteristics of indicators. You know, there's lots of different kind of things that we can look for and monitor when it comes to infection prevention and control. And sometimes we can sort of get bogged down with too many things. But I mean, the sort of bare bones of what we're looking for when we're trying to think about indicators in our M&E program, we want them to be clear, right? Understandable. What is it that we're actually, do people even know what it is that we're collecting or what it means? Useful, you know, we want to measure something that's actually going to be helpful to us and not necessarily something that, you know, won't help inform or change a practice or have meaning to it. So, you know, sometimes one of the easiest ways to approach when you think about indicators is, what is it that people are interested in seeing? You might think one thing in particular is very important and useful, but if other people don't see that, you know, maybe it's not the best one to start with, and you want to get buy-in, you want to get people on board. So maybe just start with ones that you know will be intriguing or ones that do mean something to colleagues and others in the health facility to get them on board and understanding what you're doing. Measurable. So we want, you know, that's when it comes to M&E, we do need some data. We need things to actually be discretely measured. So you can have your quantitative stuff, your rates, proportions, or your qualitative even, just doing some interviews or focus group stuff sometimes can be quite nice. Reliability. So can they be collected consistently? And validity, measure what we mean to measure. So, I mean, I'll be presenting to you in a moment a discrete piece of work that we're doing. And we do have a mix of all various types of indicators that we look at, both from, you know, process and structural mostly, but then also, you know, you can do like infection rates and that, which are much more maybe sophisticated surveillance or M&E measures even that make part of a good M&E program. Like I said, I am here representing ICAN, and I'm sure all of you are familiar with Infection Control Africa Network. In case we have anyone that's new that's with us today, apologies on these slides playing without me. Just quickly to say it's established about 12 years ago, working in 54 countries, part of the African Union groups. There's coordinators for all of these countries. The vision of ICAN is to have an African continent where safe care is provided for all patients through the implementation of strong evidence-based infection control programs. 450 financial members from 34 African countries and 14 affiliate societies. The specific activities for ICAN, education and training, webinars such as this, IPC program implementation, outbreak, creating societies, advocacy, all the good stuff. And on the right-hand side, you can see the various partners that we typically work with, of which a lot are on the call with us today. So thank you to our colleagues. And just to say that all of this is a collaborative process. So I hope no one ever feels that they're left alone to do all this work, but there are a lot of people out there, a lot of varied groups that are working in this field. So always great to cling together and make an impact as a team. Just listing here where there's been help from ICAN specifically to establish national IPC societies. Don't need to read them all for you. I'm sure some of you are representing on the call today. But this is something that we do like to do. We try to help build further because we know that even within the field of IPC and maybe in particular on the continent of Africa, the societies are a newer thing, and even the job role itself is new. So maybe take note if you see a society here where you find yourself placed that you maybe can reach out to. or if you need help with contacts, I mean, please reach out to us as well. But yeah, just to say that for IPC, it can sometimes feel overwhelming, and having that group can definitely be an added bonus. So what's an example of M&E in practice to sort of maybe help solidify and not necessarily just speak in sort of, the higher terms? So for us, we're working with Resolve to Save Lives on a particular project right now. This was, oh, sorry, I really apologize for that. This was a project that we started back in May 2020, and it is a focus on COVID-19 readiness of primary care facilities. It involves a newly developed primary healthcare facility tool specifically for COVID-19 practices and readiness, but also there are, all of you know this, I'm sure, IPC practices are fundamental to a lot of things. So we know that some of the aspects of this particular project will definitely have benefits beyond just COVID. This project has been in 2 phases. So the first phase started back in May, and it was establishing a team in 6 different countries. And then in phase 2, which now we've continued, unfortunately, we have had to downsize to only 4, in some ways just due to funding, but in terms of also progress and results achieved. And the countries there are actually in the bottom. The ones that are highlighted in yellow were the ones that we are continuing in the second phase, and Liberia and Kenya were only in part in the first phase, with some specific work happening in Uganda with my colleague Lizzie, who is on the call with us. And always feel free to chime in, Lizzie, if there's anything you feel you need to add. We made use of already established networks and national IPC contacts in this work, so that was part of the setting up. And countries we are engaging with and have finally signed a memorandum of understanding with each, so in order to collaborate on this work. The structure of this kind of project, just to give some context, like I said, right now in our current phase, we are working with 4 different countries, and so we do have country coordinators for each of those places, and under them there is the admin and data person, and then there's field monitors. You'll see on the right-hand side in the light blue, there's also in-country mentors, which has been a new step added in our work. And we'll speak a bit more to the idea of mentorship and what it plays as well within M&E. And above everything that's in darker blue is sort of the overarching ICAN team. Even within ourselves, we have project managers or country managers, which is me, specifically for DRC and Cameroon, and my colleague Choma, who manages Nigeria and Ethiopia. We have a training piece, and then procurement and logistics, as there is a little bit of IPC supplies supported in this work. What is our project in brief? And so what we're currently doing in this, and what we're trying to help ingrain, is the idea of an effective monitoring and evaluation program at a primary healthcare level, since they are the front door to healthcare. And the way the project is set up at the moment is that we have our 4 teams, and they actually perform monthly visits to these health facilities. In the first phase, there was twice weekly to sort of build up the momentum, get them into the best place possible in lead up, with phase 2 being more focused just strictly, or a lot of emphasis on their capacity building and mentorship into their specific skills. We have, like I said, a mentor for each team. There is support for field monitor development through Zoom calls, WhatsApp groups to strengthen knowledge on IPC. There's mentoring of health workers in the public health facilities, the primary health facilities, sorry. There's continuous data collection on specific IPC indicators to inform facility-based IPC action plans. We supply some necessary IPC supplies based on the needs, so during the evaluations that are performed. And then the last point is just to say there is a caveat that country visits can be performed from the ICAN team to visit, but that obviously isn't necessarily something that's happening so routinely, but we've had some chance to visit our teams and see the facilities ourselves to understand what's actually happening. So for this work, there is a new COVID-19 checklist for primary care facilities. ICAN did have one originally that they used, and a new one has subsequently come on board. with Resolve sort of taking lead in collaborating a lot of different tools that are possible to use for when doing assessments in the field or for health facilities, sorry. But this tool in particular is for primary healthcare facilities. So it is taking that context into account. There is a guide as well that accompanies this tool. So it's something that is will be widely available, and it explains each indicator and what it means, how you would observe it, verify it, and also some ideas on how to approach it with solutions if in fact that people don't have certain things in place, or just added points of consideration so that whoever is using this has a little bit to go on and doesn't necessarily just have to start from completely fresh. So this is the tool that we're using in our work, and currently comprises a total of 17 different questions, but you can see that there are many different subcomponents to this. And we've actually built this in Survey 123 as well, the app, which I'm thinking maybe many of you have used before. But it also just allows us to have an electronic or rather online dashboard to track our progress on specific indicators, but also to give at a glance of what facilities have been performed, have been audited and screened, and sort of what those results are looking like. And these are tools as well that we incorporate with our weekly meetings with team members that we use to track our own progress, but can also be shared at the facility level. We also do have hard copies of this that we actually leave with facilities, because in this approach for this particular work, it isn't about just parachuting in and meeting the facility to do an evaluation and leave. These assessments are actually left behind at the facilities as part of the documentation with their own work. And left there as reference to also make sure that they can look back to and use to help inform their own action plans, which are developed with our monitors, who basically are a mentor for the facility at the end of the day. There's also been Zoom platforms or licenses rather included in this, so each team can actually have their own and use that as another way to reach facilities in between visits as well. So part of this is also, understandably, there is a bit of procurement that happens with regards to data and making that accessible to facilities and the team that's on the ground. But it is in the day and age that we're in now, where we can't always be face to face. It's definitely something that we do need to consider moving forward, because we don't want people to lose access and mentorship or learning or whatever the case may be. And so we do need to think about technology and its role and trying to make it very accessible. So what we're showing here is essentially a quick overview of results. And so I'm not here going to show a specific performance for each of the facilities, and I've removed those names. But what I do like in our process is when our team members actually go to the health facilities, they always establish the initial assessment or baseline. And just quite simply, we use a quick color coding to give an idea of what progress is looking over time. And so you can see in the second column, the initial assessment and the subsequent visits that follow after that. And the idea here being, it's just a nice way to quickly see when people are achieving or not achieving. And the process is the monitor would go to the facility, perform the initial assessment, share the results, come up with an action plan about actionable solutions that they can move forward themselves. But then also what are ones that potentially we can support as part of the project, or who are the other partners and collaborators, or even the district health teams that are also present that maybe need to see this information and be able to use it. And so you can see on the left, under the list of indicators, there's various ones here, and they might not all make sense to you in the way that we worded them. That's okay, just some shorthand stuff here. But what you can see is it is a mix of various indicators. And so we look for things like triage and screening being outside the facility. We look at hand hygiene compliance, mask compliance, because all of the places where we are working, there is the universal masking in place. We look to see what kinds of supplies for hand hygiene are available. disinfectants, stuff for cleaning. There's all sorts of stuff that are there. And the idea here is that we want to do a broad range scope of what are the fundamentals in IPC that need to be in place, and how exactly can we ensure that they are, or support those kinds of good behaviors. We know that it takes good infrastructure or good supplies to allow people to perform the right behaviors. I think one thing I like to put in here is that, and in some cases, there isn't always, not everything has to be done in one particular way. So what I display here is just an overall glance of how people perform. And sometimes when things are green, it doesn't mean to say they're doing it, they're all actually achieving it in the same way, which I think is quite nice in this work, because there's opportunity to share that. And so with our monitors, they get dedicated to different health zones, but with our teams, they come back and they actually present on the stuff they found, both the good and the bad. And so there's this internal sharing that is inherent that happens, and also some capacity that comes there. And then that gets shared even further back to the facilities. And so although this is maybe an M&E example that fits a bit outside of a health facility's own operation of doing, it's still starting them and helping them get on board to understand the benefits of sort of continuous monitoring and evaluation, and how it can look in a very positive, good-spirited way and not be anything that's punishing. And so for all of these indicators, there are strict definitions about how we define them and measure them. But I think it's also just important to say that not one size fits all to sort of achieve these things. And so, you know, there's been some examples where some facilities do have the capacity to support masks for even patients who enter and don't have one, and that allows them to do source control measures, which we also monitor on this tool. And, you know, some facilities don't always do that, but, you know, masks are more common for patients when they come in, and so they don't have to provide that. It's just interesting to see the diversity in solutions that that I guess health facilities take on at their own ownership. And I think that's one important piece of why we see success with an M&E program such as this, is that it's actually working towards also helping them come up with solutions that fit within their work processes. And so that's why something like this, especially at a facility level, it's important to do this, because we want to see different behaviors and we want people to take action. But when there's no sort of monitoring of that, it's very hard to say that we're improving or doing anything differently. So what does this actually look like? Sorry, it's gonna play on me a little bit here. So some other specific interventions, sorry guys, I'll just let them all come out. These are just some examples of interesting interventions that have happened from this kind of work. Oh, sorry. And so the picture that's on the far left there, it looks like a stamp. So one of the things is in our tool is about screening patients who enter to the facilities for COVID-19. And one thing that actually happened in Kenya was they just developed a stamp. And although, you know, we always want good registries and documentation and all these things, sometimes it's just not the way some things work. And having continuous registrar books sometimes, you know, don't always happen. And so one solution that came up was they just developed a stamp. They put it into the little booklet that the patients, at least at their practice, came with every time they were coming for their visit. And they were able to stamp directly on the page, go through the questions, and do their screening before entering the facility. It didn't cost very much. It seemed quite simple and straightforward. And it just was, I thought, one good example of how this discussion or this solution came about because of that inherent follow-up and engagement. And so the next picture over, you can see there with the Child Fund sticker on it, they were getting, in this case, again, this was in Kenya, there was a lot of frustration about having to fill up the big jug with water, or the buckets with water, because they were always the sort of smaller Veronica one. And, you know, one of the discussions that came was that they just wanted to get a massive one that could collect water in some ways, but also that it stopped them having to fill it up as frequently And again, just discussions that happen because you're going there, you're doing this kind of work, you're asking to track something, and inherently you're going to have conversations and find ways to solve that. And so again, I personally feel this kind of interaction that comes from doing M&E and follow-up is so vital, because you're actually engaging in the specifics and not necessarily just thinking about trying to meet one indicator. The picture that's a bit hidden on the back with some arrows and squares, this was just a facility flow map that was done in DRC, which again, wasn't necessarily in our tool per se, but the idea of flow and the circuit des patients that happen in these facilities is an important factor when we want sort of the right flow of things, or the way we want to screen and where we should set up, and what is the way that patients tend to go around, where can we put hand hygiene stations. And so breaking that down and actually doing a facility map and then posting it, again, interesting solutions come of this, where then people understand, okay, this is the way our workflow will happen, and then people get into a better process. And on the bottom right, this is just examples of action plan that happen, again, from a facility in DRC. Nothing fancy, but it's the idea of taking the data that we're finding, or the observations that are being made and the data that's coming out of this, and putting it into action of how we can improve. And so, you know, we don't need to worry that we need all the different kinds of Excel sheets or whatever. We can also just do this by hand and have a discussion as a team looking at our results. And so in this process, we always have the initial baseline. There's midway presentations that happen to give them an idea of their progress and overall. But with every visit, there's always a review of the action plan of, okay, what's happening? Where are we headed? Have we addressed the issues that we've been wanting to address and look at? It's also important to highlight that this kind of work has to fit in, especially because we are a partner group that's working a bit outside. We are a partner group that's fitting a bit outside. It is important also to have the linkages of this kind of information. What I was talking about at the start was the idea of behavior change at an individual, but also thinking at a system level. And so with this work, a lot of our teams have now established linkages with their district health teams, who actually go on these visits with them, and also perform stakeholders meetings. And so these two things, and I think on our next presentation, we'll probably get a bit more on this. We do need to think about buy-in, but also the capacity building of the support system around these primary healthcare facilities. And so an undertaking an M&E program such as this, with inclusion of the idea of mentorship, is that we're able to team up with district health teams and perform these visits in tandem. So not only are we working with facilities to understand what's going on there, but we're also giving knowledge transfer, but the engagement and, I guess, reality check too with our district health teams and above of what they're actually seeing. So within this process, we do hold stakeholders meetings via Zoom, where we actually share the project findings and what it looks like. And this information is quite critical, or this act is quite critical to do, because for the decisions that are being made above these public health facilities, or the primary healthcare facilities, are impactful. And in order to make decisions that are hopefully meaningful and for the better, they also need the right information available to them to understand what are the exact challenges and successes that these healthcare facilities are achieving. And so these stakeholders meetings are one way that that is done. The results are shared more broadly. And they even go higher than that in some cases, where more formal reports are put together by our teams for submission to be able to showcase what they have found. I do want to add, actually, in our DRC team, they have subsequently been incorporated to join certain COVID-19 response pillars in their area, because they know that this work is also happening. And so it's giving them another seat and to help share the information. So we don't want to ever underestimate the power of just information, let alone the data alone, of what a strong M&E program can look like. Like I said, there is leadership buy-in when you take on acts like this. And I think that's super important when we think about the changes that we want to see, or where, you know, if funds are tight, where could they best be spent to give the biggest reward? And again, sharing findings, discussing collaboratively the solutions, and sharing lessons across healthcare facilities. I think when you go in tandem like this, you give the opportunity for realization and to really come up with things together. And so maybe it seems a bit flowery and hippie that I when I describe it like that, but I do believe that inherently one of the biggest things for an M&E program, especially if you want it to succeed, is a relationship and trust. They do want to have you around, they do want to embrace it and be accepting of it and willing to change. And a lot of that comes from setting a strong relationship. And that is something I, being fortunate enough to visit DRC and Kenya this year, that is something that I took away as a big lesson learned in this work in particular, is that can't be underestimated. And I just want to maybe really strike that home with the IPC professionals that are on this call today, because that is probably the number one trait I think that is important for an IPC professional. It's always great to have technical knowledge, but it's also the interpersonal skills that become very important. And when you have that level of trust and buy-in and collaboration, you will succeed. And so when you think about the M&E program, do not underestimate the groundwork it takes to get it up, where you build the trust, you engage them, you identify the people that do want to change. You don't necessarily have to focus all the attention on ones that maybe are a bit more stubborn. You can always start with ones that are willing and eager to have you, because organically things will grow. And so for me, that is kind of a critical point to stand on. Of course, there are many other ways to approach M&E, and there's many tools that we can bombard you with. But I thought today it just might be nice to take a moment to sort of say, okay, here's ICAN, here's something that we like to do and make it our vision and focus. And I hope that is something meaningful for all of you today on the call. By any means, if there's specific questions to this work, happy to answer them at the end during the discussion. Or if people would like to know more specifically on what sort of higher level international tools exist, happy to speak to that and the core component stuff. But for today, I will stop here and just say a big thank you to everyone.
Thank you so much, Anthony, for that informative presentation, which highlights that you do not need major resources to start some programs like monitoring evaluation programs, as you have demonstrated, putting from your experiences in low resource settings as well. You also touched on the need for leadership buy-in for some of those programs to actually move, and the importance, of course, of process improvement to ensure that we comply to infection prevention and control standards. So now moving along, if you've got any questions for Anthony, please put them in the Q&A box. And I can see that people have got raised hands. We cannot respond to your raised hands. If you've got any issues or you'd like anything addressed from presentations, please put all in the Q&A box. Without much further ado, I would like to introduce our next presenter and to take us through M&E at national level and drawing from her country experiences is Maureen Kasande. Maureen is a senior project officer for infection prevention and control and WASH at the Infectious Disease Institute in Makerere University in Uganda. She's got experience with working around Ebola and COVID-19. And because of that, the Society of Healthcare Epidemiology of America has elected her or selected her to be an international ambassador in 2020 for this commitment in Uganda. And then Maureen is currently coordinating a CDC-funded project to increase access and utilization of alcohol-based hand rubs in selected districts in Uganda, and she continues to support regional and national level infection prevention and control interventions. So to take us through their country experience with M&E, Maureen, over to you. Thank you.
Thank you very much, Noor. I'll just share my screen now, and thank you for the very kind introduction. So once again, good morning, good evening, depending on where you are. My name is Maureen Kasande, and I think most of the what I'm going to present, Noor has already given a brief introduction on that. I'd like to say that thanks to Anthony for your presentation, and most of the things that I'm going to share today are really stemming from Anthony's presentation, you find that there's quite a number of similarities. Especially he mentioned a core component number 6, being the monitoring and even framework. Nora, kindly confirm if my
Hi, Maureen. Maureen?
Your end.
Hi, I think there's something wrong with your connection. It's not really audible, it's cutting off. Maybe if you can,
Hear me?
Hi, Maureen. I think, yeah, could you speak again so that we can hear you? It's breaking off, so I'm not sure if it's to do with your internet connection. Can you go ahead and then we hear if it's audible?
Yes, I can hear you loud and clear from my end.
Okay, great. Now we can hear you. If you could, if you don't mind, just going back to your, 2 slides back. Yeah, thank you so much.
Right. So I just already said that most of my presentation will be quite similar to what Anthony shared in his presentation. So if we go to the next slide. Next slide, please. No, next slide, please.
I'm sorry, just give me a second. Sorry, everybody, for the glitch. Just sharing Maureen's slides. And starting from the beginning, and there we go.
Yes, thank you very much. So sorry, apologies for that once again. I was just picking up from Anthony, and one of the things he mentioned in his presentation was the role of monitoring, audit, and feedback as part of the WHO IPC framework. And here are the core components really highlighting the need for M&E. Next slide, please. Yes, so I also thought to share the differences in the meanings of monitoring and evaluation. And I think Anthony also gave us a really fantastic definition of the two. So we'll skip that and go to the next slide. So really, to break down the goals of M&E programs, one is to really ensure that we establish a robust health system, and also to define the sound and functional M&E system around our IPC programs. And then finally, to ensure improved availability of quality information. And of course, this is used in the decision-making regarding our IPC programming. Next slide, please. So just to go down to looking at the objectives in the healthcare settings, most of my presentation is around the healthcare setting, and I'll also give a little bit of the national level programming. However, most the objectives are around understanding the role and structure of IPC programs, and also looking at establishing a technical working group, establishing a well-developed data management system and developing a system for linking the national M&E system to the healthcare facility M&E system. So some of the improvements that Anthony shared in his presentation, which could be similar to some of the improvements we've seen in our own IPC programming in Uganda, it's really very relevant for us to link our gains from the healthcare facility level to the national system, so that we see so that the improvements are visible at national level to aid decision making at that level. Next slide, please. So very quickly, what is the role of M&E in IPC? We thought to just give a rationale for the M&E here, and really it's to achieve behavior change. We've realized that IPC components or compliance is more of a behavior change aspect, and so we think that M&E helps us to really keep track of these changes, and then to document progress and impact, and also to align with other monitoring systems that are needed. We find that there's a lot of integration, just not IPC is not a standalone. We look at it in intersection with the quality assurance programs and others within the healthcare setting. So M&E helps us to look at these synergies and approach the issues much better. Some of the examples at facility level, some of the examples at facility level are audits in hand hygiene, waste management, and also environmental cleaning. Somebody is saying they can't hear me. No, can you confirm that you can hear me before we go to the next slide?
I can hear you. Lizzie, can you confirm if you can hear her clearly as well?
Yes, I can hear her clearly.
All right, thank you very much. So I was just, highlighting the different audits that Anthony already highlighted in his presentation. So we'll go ahead to the next slide. So these are some of the guidelines when planning out an M&E program. We look at planning and evaluation. We look at selecting appropriate methods. Some of the methods may not be applicable in some of the settings. So we need to look for a method that is applicable, collecting, analyzing the information, and these findings should be reported, and then implementation recommendations are drawn from the above guidelines. So once we have such a framework in place, we're able to establish an M&E program, not only for IPC, but for other related activities. It's really, really important to look at indicators, the standardized objective measures that follow comparison among the health facilities, and we shall see that later in our experience. Looking at the different time periods, for example, we like to say peacetime and wartime. How was IPC during without an outbreak, and how are the routine IPC, and are there any improvements during the outbreak? So some of these indicators help us to tease out certain changes or certain improvement. And then they help us to, give us a roadmap to achieving the program goals. So it's really important for us to develop IPC and WASH indicators with a clear definition, and at least tease out maybe just 3 to 5 indicators that can be incorporated into the National Healthcare Management Information System, such that it is not a standalone at the health facility for you to measure some of the healthcare facility indicators, but to rather have these reported at national level at a routine basis. I know that we have been measuring our improvement in terms of HIV care, TB. So I think that IPC indicators should make it to the National Healthcare Management Information Systems for our countries. Really, our main focus has been around, the main focus of monitoring is around objectives and outputs, while evaluation, we're mainly looking at outcomes and impact. So let's move to the next slide and look at planning. How do we plan? How do we collect and analyze this information? First, we have to have proper applicable data collection instruments. We, at the beginning of the pandemic, if I may give an example, we had all sorts of tools, some that were applicable within our resource limited settings and others that were not. So we had to align the tools to our setting. So it's really important when we are setting out to collect and analyze information to look at developing appropriate data collection instruments, pre-testing these instruments, and then we can go on to undertake the activities, analyze and interpret the data. How we select the appropriate methods is, looking at the questions, the evaluation questions. What do we want to evaluate, or what do we want to measure? How do we decide on the appropriate evaluation design? Are we going to compare? Is it a comparison? What kind of design do we want to undertake in that kind of M&E? And then of course have a schedule and a budget that is supportive of your setting. If it's resource limited, we have to find out how to leverage on partners, partner engagement to ensure that we meet some of the resources that are required. Over to the next slide now. So coming into Uganda, and one of my requests was to share the Uganda experience. What have we been doing? What tools are we using? So we have different kinds of assessments. We conduct the annual IPC survey. The WHO encourages countries to conduct an annual IPC survey to measure our IPC compliance against the 8 core components, against the hand hygiene, and also the self-assessment framework, which I hope that most of us here are familiar with. So the IPC assessment framework really supports implementation and monitoring of the 8 core components that I shared at the beginning of the presentation. The hand hygiene observation tool is really an audit tool for the 5 moments of hand hygiene within the healthcare setting. And also the hand hygiene self-assessment framework is around the 5 multimodal strategies, which include reminders at the workplace, education and training. And these tools have helped us in Uganda to look at IPC compliance. We have done this since 2017, 2018, 19, 2020, and we are planning for our 2021 IPC survey. I'm not I did not get consent to share the results on this platform, but this should make it to a document that will be published for us to look at. So that consistency in conducting IPC national survey helps us as countries to measure our compliance and see our areas of improvement. So far, these are tools that we use in country. We also conduct quarterly IPC survey within our regional referral hospitals. And here we use a more basic assessment tool where we go down into the healthcare associated infection and also surgical site infection surveys, which are point prevalence. So looking at such data helps us to see how to guide and develop training materials and curriculum for our healthcare workers to adopt some of the IPC practices. So at facility level, I think this is one of the assessment, the decisions that were made at the national level to conduct an IPC mentorship. And so the IPC mentorship, especially for within the COVID-19 action plan, was to really look at all the healthcare facilities. And in a presentation that I made earlier, we mentioned how we in Uganda have used the IPC mentorship to reach out to all healthcare facilities using a partner engagement approach to support IPC mentorship in the different regions, and so to speak. So what we did was leverage on the partners to, have mentors, which mentors go to the different facilities and conduct mentorship, and at the same time conduct an assessment. So this is a tool that was developed to support that venture, and it was endorsed by the Ministry of Health, and it was turned into a digital version, as such that a healthcare worker, a mentor, is able to assess online and submit the results in real time. I like to say also that this ODK is connected to the national IPC dashboard. We can go to the next slide and see how this plays out. So we came from the paper version, where we designed an appropriate tool to assess IPC components, and then turn this into the electronic version that we see in the middle. And so the data from the electronic version goes straight into the Ministry of Health IPC national dashboard, such that within the Ministry of Health, whoever has access to this link to the dashboard is able to see how districts are performing. And it's possible for somebody to zero down to the healthcare facilities and understand why are some still not performing well. And the traffic lights scoring means that green, somebody the health facility is competent, while yellow is an intermediate, and red means that it's not yet at a satisfactory level. So by looking at the national dashboard, you're able to tell which areas are still in red and which are still in green, and then be able to dissect further to understand what could be the challenges. Could they be in IPC programming, organization? Could they be in waste management? Is the problem in hand hygiene? And so decisions are able to be made at a national level, so that this kind of data helps to solve problems at facility level, district level, at national. Next slide, please. So what we did was to review data, and we also conduct quality assurance of this data, train, and these mentors are assigned to, so a mentor is assigned to a health facility, to 2 health facilities. So what we have is, we had to train.
Sorry, Maureen. Can you
I kind of press for somebody to mute.
Can we mute our microphones, please?
Thank you. So how we did the data review and quality assurance was to ensure that the users of this data collection tools are trained on both the paper and the electronic tools. And we know, of course, that once the internet is challenged, so that we have the paper base, which we can later enter into the ODK and submit. And it provided real-time support for the ODK users in case there's a challenge while a mentor is in the field doing mentorship at a certain facility and they're entering data and there's a challenge, there's real-time support for that. And we conduct support supervisions. The data is cleaned for completeness and accuracy. It's analyzed and then disseminated through the dashboards and performance review meetings that are conducted monthly or quarterly in the different regions. Next slide, please. In the picture is somebody, one of our trainers training on the ODK. Next slide, please. Next slide, no?
Sorry, I'll just be, it seems to be stuck. Just give me a minute, sorry.
Right, so really as a take home, what I liked for us to walk away with is, so it's the same, this is the same information that I shared in the previous slide. In the interest of time, I like to go to the second last slide. Yes. So what are the gains from this monitoring the IPC interventions? Baseline assessment, like Anthony mentioned, informed planning and targeted interventions, timely feedback, stakeholder and partner engagement, collaborated approaches, and also buy-in from the national stakeholders towards institutionalizing IPC. So this kind of data helps the decision-making. It facilitates buy-in, in which we are really trying to get in our different regions for national level buy-in. So such kind of that. So as I conclude, one of the things that I'd like for us to take home with is, do we have an M&E structure at level? Do we have somebody that is designated at national level to look at our IPC data and is able to share this information with our IPC national level stakeholders to ensure that this information is put into consideration while making decisions. And that's at national level. What about facility level? Do we have somebody at facility level that encouraging the IPC focal person for continued data collection at this data makes it to the national dashboard, where once we have buy-in at the national level and we have an M&E person specifically designated or just augmented to support M&E at for IPC, to incorporate indicators for care delivery. If we have that kind of system at national level, I think we are able to have robust IPC systems. I thank you so much, and I hand it back to you now.
Thank you so much, Maureen, for that very informative presentation. Apologies again for the glitches with the presentation, but I'm sure we did get a lot of information that can guide in our decisions when it comes to M&E in our various centers. Maureen did touch on how monitoring and evaluation from facility level feeds into the national system and into their national dashboard. And this also guides in decisions for process improvement around infection prevention and control. And she did ask some very vital questions as well, which for us, I guess, even as participants, is for introspection when it comes to our various institutions where we are, on where we actually do stand, and maybe the kind of work that needs to be done. Thank you, Maureen. That presentation was relatable. And it also points to that you do not need a lot of resources to actually start monitoring and evaluation based on how Uganda started, that is with the paper-based system. Without much further ado, I'd like to hand this over to Lizzie, who is going to be taking us through our Q&A session. If you've got any questions that are burning for our presenters, COVID situation in Africa, and to Anthony or to Maureen or to our esteemed panelists, please do put them in the Q&A so that they can be addressed during the session. Over to you, Lizzie.
Thank you, No. Good afternoon to everyone, and welcome to our Q&A session for today. And welcome to our panelists that are from CDC, US CDC, Africa CDC, and ICAN. And our first question is directed to Anthony. It says, in your experience, what types of support are provided at district level, and what areas of logistics support would your organization, that is ICAN, provide based on the deficiencies that have been identified through the M&E process? Over to you, Anthony.
Yeah, thank you for the question. So in terms of what we provide specifically to the district level, I'd say more right now it's a bit more of a quasi mentorship, let's say, because we encourage their presence as part of the actual visits that we do. So we're not necessarily doing something specifically targeted at them, but we know that they can't be left out of the process, especially as this is an externally funded project. We want their insights to what we're seeing with regards to IPC and how it can be improved. And so the idea of accompaniment in there and having their involvement in the process we see as vital. So that is sort of the, I guess, the max level effort we're putting directly at the district level. Additionally, like I said, with the stakeholders meetings and how we share the data and information, they are of course included in that, and support given to be able to connect everyone via Zoom, and Echo and other platforms. Actually, I should be more specific. So that's sort of the extent to which we do that. And in terms of the logistics support based on deficiencies identified, this is specifically around some IPC supplies. And so we look at what kinds of stockouts have taken place during the last month. There is some budget to procure some items. Obviously, that's not going to be sustainable for years and years, but at least for the immediate moment that we're facing with the pandemic, we're able to help support getting things like ABHR, soap, buckets, So the buckets being more long-standing items, MOPS as well, things like that. And there have been some triage facilities, or triage facilities, the right word, built for some facilities to support their screening process, especially for the larger ones, so that there's a sort of better management of flow and integration there. Over to you, Lizzie.
Thank you, Anthony, for that. And for your next question, in some of the examples that you gave, I think it's the one from Kenya, where they devised a stamp with the questions, the screening questions. Musa here is asking, like in a case where the stamp is not available, what can you use to record the screening of patients? Over to you, Anthony.
Okay, well, I take no credit in the stamp because I would never have thought of the stamp. And I don't necessarily have the answer. So I'll invite panelists to come in if anyone else has other solutions. The obvious one is just having a notebook. Some log that can be kept where you could maybe put, a small table of date and the questions you want to ask each person, and you can sort of record that. I mean, there's different types of registry books that one can buy, usually not too expensive, but obviously with rain in that, they can get damaged and, blah, blah, blah. So personally, that's my default answer. Get a registrar book. That's an easy to use logbook. I personally like the stamp because it just seems to be more low cost over time. But at the end of the day, what's most critical for me in the process of screening, I believe in documentation, don't get me wrong, but just even having someone to ask the questions to the patient who's coming in and take their temperature and then direct them on where to go is actually the most important thing that we can be doing. So the easiest solution is having someone there to ask the questions and know where to send them. The documentation piece is definitely important and a sort of secondary item to completing that process. But I welcome Lizzie, Wande, anyone from Africa CDC or our CDC colleagues here, if other people have solutions, but I can't say that I have a ton on how to solve this exactly if you don't have the stamp, but happy to welcome other opinions. Over.
Thank you, Anthony, for that. And I would like to invite the panelists, if there is someone with additional comments. Okay.
This is Elizabeth Bancroft from CDC. This is a tough problem everywhere, how to be able to monitor this and follow each person. And I'll be honest, I'm not sure that we've even solved it in higher resourced countries, ones where we have electronic, monitoring of people, or many more personnel who can follow up people. It's still a work in progress, even domestically in the US. So I actually very much applaud the ingenuity and the creativity to come up with all of the different ways, things like stamps in Kenya or other registries that we're seeing through these projects. Over.
Thank you, Elizabeth, for that. My next question is directed to Maureen from IDI. Laywell is asking, in terms of cost, will you be able to project an operation cost for each audit experience and how you're sustaining the ODK platform? Over to you, Maureen.
Thank you so much. Thank you very much, Lizzie. And I also thank Elizabeth for that comment that she just made earlier. To answer the question, in as much as possible, we want to make this M&E or intervention very cost-free. So if we can leverage on the IPC committees that we make, that we form at facility level, and then leverage on those committees to ensure that data is collected at a monthly basis, then we are able to have comprehensive data. Concerning the ODK, I mean, the ODK is freely downloadable. and each person is able to have that as long as they have a smartphone, and then this information is sent directly to the server that you'll be using. If this server is connected to the probably the national dashboard, is where I see some cost. Who will look at this data? Who will look at this information? Who will make sense of it? And so that is why we really strengthen a national buy-in in such kind of data and information sharing, so that somebody is designated at national level or are co-opted from other M&E work that they're doing at national level to also support the actions at levels. Data collection shouldn't be a challenge. Maybe the challenge would be its consistency and the bias. Remember, this has an aspect assessment. When it comes to self-assessment, we may be worried about the data that is collected, but we can also, recently we've been looking at an exchange program. Can we exchange with the next facility and, you know, have people assess each other? And, or could we have somebody that is external from the IPC committee conducting this assessment, and so that we can have a true picture of what is happening in terms of the IPC compliance indicators within each facility, and then that is put in the dashboard. So to answer your question, really, we need some resources, while in some areas we may not need as much resources, but instead leverage on the existing capacity that we have built over.
Thank you, Maureen, for that detailed response. My next question is directed to the colleagues from Africa CDC. Dr. Ario, maybe if you could tackle this one. This is from Emilia, and she's asking, where does vaccination of healthcare workers in IPC lie in the M&E tools? The concern is for the healthcare waste handlers who are often in direct contact with hazardous material. Over to you, Dr. Ario.
Sorry, can you come again with the question?
The question is from Emilia, and is asking, where does vaccination of healthcare workers in IPC lie in the M&E tools? And the concern is coming from the healthcare workers, handlers, who are often in direct contact with the hazardous material.
Okay, vaccination of M&E. Vaccination of healthcare workers, whether it lies within the monitoring and evaluation in IPC.
Yes.
No, I think vaccination it lies within the preventive measures to control the infection of healthcare workers. Monitoring and evaluation is when you have set up your program and you want improvement. Vaccination is a different area entirely when it comes to IPC, if I got the question correctly. So vaccination prevents infection, and it makes sure that our healthcare workers remain safe and they continue to provide the services they are meant to provide. Over.
Thank you, Dr. Ario, for that. Next question is...
This is, if I may, sorry to interrupt.
Please go ahead.
I think there is a role, though, in M&E in monitoring the progress of vaccination of healthcare workers. For example, I think one of the part of the question was also related to like waste workers and waste workers and vaccination. And for example, for many places, it's really important to get healthcare workers vaccinated against hepatitis B because of all the potential sharps injury that could spread hepatitis B. That would be sort of in, the non-COVID, as Maureen said, the peacetime type of IPC. And in that case, I think there is a very strong role for monitoring and evaluation to monitor how well the programs are going to get healthcare workers vaccinated, if that is indeed a priority at that health facility or through the national MOH, and then to evaluate to see what percentage of your healthcare workers have been vaccinated. I think this is going to come more and more into play as COVID vaccine becomes more available on the continent, and that facilities are really going to want to monitor just what percent of their healthcare worker population is fully vaccinated. As I imagine, the ministries will also want to know what percentage of the healthcare workers are fully vaccinated, as they are healthcare workers are often targeted to be first in line for vaccines. Over.
Thank you, Elizabeth, for that. And I see Prof. Robertson also has something to add in. Prof. Robertson, over to you.
Yes, I'd like to agree with Elizabeth. And in our M&A tool, we do monitor, we have one that we're using as part of an RTSL project, and we're including monitoring of healthcare worker vaccination. But we like to see it as part of an overall occupational health program for health workers. Elizabeth mentioned hepatitis B. We also have an issue of TB transmission in health facilities. So we should be looking at the safety of health workers in their environment, and infection prevention and control programs should be concerned with healthcare worker safety. One of the instruments for that is vaccination. In this case with COVID-19, we have an instrument that can be used. I know countries monitor it in different ways. Our epidemiology unit monitors the vaccination numbers, but we also really try and encourage facilities for health to get their healthcare workers vaccinated as well. Thank you.
Thank you, Prof, for that. My next question is directed to you, Prof. Kolibali is asking, how is ICAN collaborating with countries where it is not represented? Over to you, Prof.
I think the word collaboration involves a two-way process. So ICAN works with different infection control associations and has worked with countries to develop their associations, and apologies to Malawi for not having them on the slide. That will be rectified. But also we have members, individual members where there's no associations, and we encourage them to participate in ICAN activities, express how they would like us to help them, and we can have conversations about how to do that. So, in a sense, there are more countries, individual members within countries who are members of ICAN than there are associations. So we work with people who reach out to us.
Thank you, Prof. Robertson, for that response. Yes, and my next question is directed to our two presenters. Maybe if Anthony can tackle it first, and then Maureen follows. Michael is asking, how do you set up IPC strategies in the community using the community structure, and how does M&E help to improve them? Over to you, Anthony, and then to Maureen.
Talk about a tough question. Okay. Yeah, I don't have the solution for you up front. I think there's some points of advice that I would consider when thinking about the community would be these. So I think when it comes to the stuff that we presented to you today, they're large parts health facility focused. And that's simply because health facilities are a realm that we have a bit more structure and sort of, I don't want to say this word per se, but it's a bit more of a controlled environment where we can sort of impose the rules of healthcare that are safe and guiding to ensure good quality care to patients and protection to staff. So a large part what we have shared is focused on that, and that's what a lot of and that's why you find those things to be specific to healthcare facilities. I think when we think about the community aspect, especially for primary healthcare facilities, I would say actually thinking about how they can engage to inform what the health facility can do. So I mean, there's the simple ideas of like suggestion boxes. There's the community liaison people that exist. There's maybe a leader within the community, whether that's like a mayor or even spiritual leaders, sort of that kind of community engagement to actually understand what are the fears or the misconceptions that maybe the community has towards what the facility is doing. And so I think within the patient engagement is kind of what I tend to call it, or community engagement, that aspect is built into some of the hand hygiene tools, in particular having a hand hygiene improvement program. There is a patient engagement piece that you could look at for some further ideas. But I think when it comes to sort of the M&E of what we talked about here is that the patient is who we're serving. And so we do need to have their voice included in the feedback that we get, and how that can look within your M&E program. That can depend on what the goal and objective that you're trying to achieve. But if it's to inform practice and understand their perceptions and why they're not following certain rules, or why they question, or do they have questions, I think is important to help in your planning process, and seeing what you come up with in terms of what you might try to change, see how that gets impacted, maybe do surveys with the community to understand if they're happier with the services, what their experience has been like. There's that's a whole M&E thing in itself, just that the satisfaction of services and engagement from communities. But I'll stop there and hand it over to my colleague.
Thanks, Anthony. I'm glad you went fast. I'm a big proponent of engagement, whether it's community engagement or partner engagement, to be able to solve some of the community-related issues. So stemming from what Anthony already said, it's something I also thought. We have something called the community liaison, and for us in Uganda, that's the village health team, or if you want, community-based health workers. So these are a liaison between the health workers, the health facility and the community. So what we have done on our end is to ensure that during the IPC mentorship, the village health team or the community health workers are part of the mentorship. They are also trained at the health facility where they are attached. And the role is for them to go into the community and pass on the information that they have picked up from the training, and trim it down to what is relevant to the community. The other approach that I know about is something called the household or home improvement program. And that is usually run by community-based health workers who go from house to house, ensuring that some of the IPC, so to speak, or some of the hygiene and sanitation structures are in place in each home. And that way we are able to strengthen or improve IPC within a home. So how does M&E come in here? I think that's the paradox. How do we incorporate M&E structures into these kind of suggestions? It is for us to come up with, and I know that these tools are there. There is a checklist, like a checklist that can be used by these community-based health workers for them to go around in each home, and they are, doing this kind of work in terms of home improvement. And then after a certain period, they can use the checklist to track progress, and then, share it back at either sub-county level or district level, depending on where you are. So that seems to be the two approaches that we have. That we have, and also we can leverage on the existing systems and religious leaders and the other structures within communities that we can leverage on to pass on information and then later measure it using a sort of checklist. Back to you, Lizzie.
Thank you so much, Maureen and Anthony, for that. And my next question is directed to Elizabeth. As we know, CDC has been a major driving force in supporting IPC programs across Africa. So in your experience, what role has M&E played in improving IPC programs or also guiding in decision-making from both at national and facility level? And if you can briefly maybe talk about your experience for the past 5 years. Over to you, Elizabeth.
Sure, thank you so much for that question. In many ways, we were very involved with trying to use the principles of M&E while we were also trying to use the principles of continuous quality improvement, or CQI, which often, incorporates kind of that M&E principle where you're always studying, the plan, do, study, act framework, where part of it is always studying what you've done, studying the effectiveness of it, studying studying what effects you've had, how well you've implemented something, and then continuing the cycle to continuously improve things like whether it be hand hygiene, waste management, or other activities. I have to admit that prior to the pandemic, I don't think we did as good a job with systematically setting up sort of M&E frameworks, or really supporting M&E frameworks. We did it with things like WHOAFRO, again with Marine in Uganda, in the context of EVD, Ebola. We did start doing much more systematic M&E and supporting groups and countries with systematic M&E for preparedness for facilities for Ebola. Now that we've moved into COVID, I think we're being much more enthusiastically supporting M&E, not just for the COVID, but really us trying to work on what happens when COVID goes away. How do we keep sustaining all of the good investments that have been made in IPC, and how do we use M&E to keep showing value of those investments into IPC to stakeholders, to ministries of health, to other funders and donors, in recognizing that M&E can really show all the value that's being done in IPC. And to that end, we're actually trying to work with large organizations, organizations like PEPFAR, which many of you are familiar with, to try to understand how we can measure better the effects of IPC in sort of a peacetime way, so that we keep making progress throughout the continent. Long story short, we weren't as involved as we should have been in systematically developing M&E tools and supporting them. We started doing a lot more in the context of Ebola, then much more in the context of COVID, and now our eye is looking forward beyond M&E for emergency response, but how do we get it systematized in countries that are interested for peacetime IPC response?
Thank you, Elizabeth, for that. And finally, just to our two presenters, any take-home messages to our participants who have joined us and they are in different stages of actually implementing the M&E framework for IPC. Over to you, Maureen, and then to Anthony.
Thank you, Lizzie. I first thank ICAN and Africa CDC for the opportunity for us to share and learn from each other. My take home is maybe 2 points. One is that it starts from systems that we put in place at national level. Without some systems and structures, most of the M&E that we would want to do may not be possible. So think about it. Do we have an M&E framework? Do we all have a national M&E framework that is specific to national level structures and also specific to facility level structures? I think when we have such kind of guidance, you know, the IPC policies and guidelines that are up to date, these documentation and guidance help us to strengthen these structures, these M&E programs within our setting. Then two, it is not, it may look so complicated and very hard to achieve, but I like to encourage all of us here that we can begin from what we have, the resources that we have, the expertise, the skills that we have, and slowly by slowly we should get there. It's very helpful for us to look at the existing documents at international level. CDC has very good guidance, and WHO for IPC indicators that we can look at and try to align to our setting and begin from such a level. And also, you know, consider conducting monthly surveys, starting with a small pilot, maybe 2-3 health facilities, and slowly learning from that, it should now grow into a nationwide implementation plan. That's all I could say, Lizzie, and back to you.
Thank you. Over to you, Anthony.
Yeah, I think for me, the biggest thing, and I see that there was kind of a question that was asking about how do you convince people, private sector, they just want to have good rates and benchmarks. I think for me, it was kind of what I was ending on. You need to know what sells and what they're interested in. Sometimes that isn't always going to be what you're interested in most in achieving first, but that isn't a bad thing. I think when it comes to effective M&E, it's about incorporating what people are interested in and what's going to get their attention. And so I think when you go into that with the planning phase in particular, you can find that you'll probably get more buy-in as you move forward, and you will tackle the things that are also equally important, that we know objectively to be important. It just may not be what they want to work on. And I think when it comes to the pressure of just trying to achieve a good benchmark and having 100% hand hygiene compliance, I mean, first of all, you'll never have 100% hand hygiene compliance. We're humans. We will always make mistakes. It's, you know, things like that are just not real. So I think it comes down to the relationship you have with your colleagues that you're working with, and how that will actually shape their thinking. So if you can take that relationship piece very seriously, find the foot in the door, what will be that thing, I think you'll have a lot more success, and that will look different in many different countries. And so there's never going to be a one size fits all solution, but I do believe you will find one in that collaboration. Over.
Thank you so much to our presenters and to the panelists. I'm now going to hand over to No. No, over to you.
Thank you so much, Lizzie, for that Q&A session, which was very informative. At this point, I'd like to thank our participants, thank our panelists, and thank our presenters, and all those who are behind the scenes for making this session today possible. Just a reminder to all our participants that the French session they can catch it on Friday. And just also a reminder for you to register for our next week's session, for session week 3 of webinar series 7 for next week. Please do join us as well next week again. The lectures will also be available on the ICAN and CDC websites, and we'll also be doing Facebook live streaming. Another reminder as well that all sessions are recorded and will be made available to all who have registered to attend this session. If you've got any burning questions around the presentations or anything else around infection control that you think we might be able to assist in, please send an email to Susan Cassie, with Cassie being KESSYS at africa-union.org, or you can send them to Anna at icannetwork.co.za. And with that being said, we have come to the end of our day, and I'd like to thank all the participants and hope to catch you next week. Thank you so much. Bye.
Thank you.